Hello everyone, Medic Level Up here. We're back again with another video. We're going to be discussing the most common toxins, electrolytes, and a couple of metabolic effects. Let's get started. So we're going to start off by talking about potassium, so hyperkalemia and hypokalemia. Remember that the first change you will see in hyperkalemia is related to the T waves. These are tall, tented, and pinched, as opposed to hyperacute T waves of ischemia. Those T waves are going to be more broad-based and rounded at the top. Hyperkalemic T waves are more pinched, slim, narrower, as compared to those T waves. You can also have PR prolongation, so some degree of AV nodal blockade. And you can also have prolongation of the QRS complex. But this more or less happens with rising levels of potassium. The QRS complex widening can be followed by a sine wave pattern, but this is mostly a pre-terminal rhythm, and the patient can progress towards VF and cardiac arrest. The next one is hypokalemia, so a low level of potassium is going to cause certain changes on the ECG as well. These are mostly related to the presence of U waves. You can also have some degree of ST depression. Now, there are a couple of variants of the U waves that we're going to be looking at in a while. So you can see that there are different variants of the U wave when it comes to hypokalemia. The next one is calcium and its effects on the ECG. So hypercalcemia is going to cause a short QT interval, and a hypocalcemia will cause a long QT interval. Now, both of these changes are because of shortening and prolongation of the ST segment. The next thing we need to talk about is hypothermia. Now, we've got a really nice picture over here that shows us the Osborn wave, also known as the J wave. This is basically a notching or a pointed wave that forms on the J point, and it's mostly visible in V5 and V6. So let's talk about toxins now. First of all, beta blockers, bradycardia, hypotension, and PR prolongation. There's only one beta blocker that is going to cause some degree of QRS prolongation, which is propranolol, and it increases the QRS duration to more than 0.10 seconds. Tricyclic antidepressants are very infamous for causing ECG changes. The TCAs are mostly responsible for causing changes on the right side of the heart. We've got a broad QRS complex because of the interventricular conduction delay, and the QRS is prolonged to more than 0.10 seconds. Of course, you can have some degree of sinus tachycardia with these cases. Since the TCAs affect mostly the right side of the heart, you can have right axis deviation and a right bundle branch block. The most characteristic finding of TCA poisoning is when you look at the lead AVR, you will see a R wave, which is taller than 3 millimeters. You can also calculate the R to S ratio in AVR, and if it's more than 0.7 millimeters, then you're certain that this could be TCA poisoning. The next one is digoxin. Now, in order to learn about digoxin, we have to understand that toxicity and digitalis effect are two different things. Let's talk about effect first. So the image you can see over here shows you the scooping of the ST segment and slight depression as well. This is known as the thumbprint sign, or sometimes also called the Salvador Dali sagging sign. Along with these effects, you can also observe a short QT interval, and you can have mild PR prolongation on the ECG as well with digitalis effect. Now, toxicity is different as compared to effect. You can see systemic toxic side effects of digoxin and, of course, arrhythmias on the ECG when toxicity is there. The most common finding with digoxin toxicity is going to be ventricular ectopy. Now, there are two arrhythmias which are very commonly associated with digoxin toxicity. The first one is a bidirectional ventricular tachycardia, in which you have QRS complexes that are in two directions, something like this. The second arrhythmia is an atrial tachycardia, and the AV nodal blockade is going to show you a 2-to-1 block pattern. So it is going to look something like this on the ECG. So a 2 P waves in a single QRS complex, a 2-to-1 block. The next is two things that I want to highlight over here. Dish toxicity in the presence of atrial fibrillation and in the presence of Wolff-Parkinson-White syndrome. So if a patient has dish toxicity and there's atrial fibrillation, there's going to be some degree of regularization of the ventricular rate when it is very slow, something around 40 to 60 beats per minute. And with Wolff-Parkinson-White syndrome, the bypass tract can allow the ventricles to go at a very fast rate. That's all for today. Let me know in the comments section if this was helpful or not. Don't forget to like, share, and subscribe to the channel, and have a good day.